But from what we just heard Lynn talking about with the classifications, why don't we try and provide the certainly the MBI available classifications for this lesion. So if we pause it here, nice 2.
Yeah, absolutely. It's not nice 3, but a nice 2. But can you activate a near focus mode so that we can get a much detailed view of the vessel patterns?
I think for nice, I think the message out there is you don't need this sort of magnification, but for the other classification systems, you probably do need this close magnification. So
yeah.
let's just,
could you freeze this image here?
Yeah, good.
I think it's a very typical appearance of the GIENET 2B. If you are familiar with the GIENET classification, actually the vessel patterns which are visualized in the center of the image are very, very typical appearance of the type 2B.
I don't think we have it ready to go, and we're not routinely using it. And what for you? I mean, would there be added value of chroma endoscopy here versus virtual?
It's a very tricky question. Yes and no. If you are not so much experienced with the chroma endoscopy under the use of magnification, there is no use of using chroma. But if you are very much into this field, it's very useful. Actually, some studies show the additional value of using the chroma to the NBI-based observation, but it's a kind of very tiny or small area.
Incremental benefit.
Yeah, incremental benefit, maybe 5% more or less.
And that's in the hands of someone who's good at it.
Yeah.
In my hands, I think the incremental benefit is 0.
I'm not sure.
Probably it's got a decremental benefit. So I think that's worth pointing out as well. And the thing is at a bad angle. So I can't really show you what I want to show you, although maybe now I can. We just lift the tip up a little bit, that's much better. Push it out a little bit, and then we can see what we have, right? So we clearly don't have a big piece of tissue, and then I'm just going to gently close the snare to a bit of resistance, and then apply 1 tap of diathermy. And then probably it will be all right now, but let's have a look and see.
I think so.
See what we think. Get that out of the way. So there's a lot of fibrosis there. We do see that, right? In these non-granular polyps, you very often see fibrosis under them, even if they're not previously attempted. I'll just freeze that. But this looks okay. So that's what to think about there.
When it comes to the lifting, we should not underestimate the risk of the non-lifting or less lifting before we start the treatment.
Yeah. And I mean, I think that it was interesting because that looked like a very easy polyp. So I was saying to you, Ichi, I'll just do a few polypectomies before we go on camera to see it. And it just wasn't very easy. So I think these non-granular polyps, they are difficult. They're more difficult injector to resect. And the characterization is also difficult, I think, as demonstrated here, that you don't have, you don't often have the key things that you would often have.
Yeah. We have Naz joining us remotely. I just wonder whether we should just bring him in here. He's been watching very intently. He's got a very serious face. And,
are you talking about the same Naz that I know?
Yeah. Well,
I have a very serious face, as I remember.
we use it with. Anyway.
I was looking into that defect with much more intensity than David, who was very nonchalant saying it'll be fine. But no, it does look fine. But no, I certainly think, I mean, that is an excellent example of incomplete mucosal excision. And once you've seen enough of them, it's obviously quite striking to identify. But re-excising really is the predominant thing. So I think that was an excellent demonstration. And certainly points, yes.
My question to you is, why am I doing this? Yuichi said this has got GIENET 2B, and I'm doing this piecemeal EMR. Why is that?
Yeah. So, look, I think from the point of view of the lesion assessment, I agree with you, David, that I think keeping it as simple as possible is, and taking the classifications away for just a second. I mean, really, this is a lesion that obviously is non-granular, difficult in the transverse colon. But in a general, as you say, the blink thing or the overall thing, like it is homogeneous. There's clearly no areas that concern you in terms of true demarcation. Sure, there could be a bit of CUDA 3, a bit of CUDA 4 around, but overall, to me, this is a benign predicted lesion. And as per the standard ESG guidelines and the American guidelines for benign predicted lesions, I think PCMR is a perfectly reasonable approach to the resection.
And Yuichi, do you think that this has cancer in it?
I'm not quite sure. The risk
Slowly
of having cancer is, of course, less than 5%, but it's not zero. So maybe because of the size, some people prefer doing ESD, some people prefer doing piecemeal EMR. It's just subject to discussion, I would say.
Well, do you think, Yuichi, it depends on the patient a bit? I mean,
yeah, of course.
And so this patient is relatively, I again forgot the case presentation. You should have told me. We don't know how old is this patient? This patient is 52. So I think that has an impact. The age of the patient has an impact. That's absolutely 100% true. And let's have the injector, please.
I think multiplicity.
Comorbidity. Multiplicity.
Multiplicity of the lesions is quite important because this patient has a lot of large polyps. So you can't spend 1 or 2 hours per each polyp.
Yeah, I think that's right. And I think by doing that, we potentially simplify a quite difficult and complex set of classification systems into something that is relatively sensitive, actually very sensitive, and relatively specific for the detection of cancer in colon polyps.